Hey everybody. So dizziness is one of the most common things that you're going to see both in the clinic and in the ED. And neurologically, vertigo is a manifestation of quote-unquote dizziness. Now, anytime a patient comes in and says that they're dizzy, you need to figure out, is this vertigo or is this pre-syncope? We're going to focus on vertigo here because there are a lot of neurological implications. However, pre-syncope is another very common cause of dizziness, which needs to be discerned as well. So, vertigo versus pre-syncope. Vertigo, which we're going to talk about here, is a dizziness that usually is described as spinning. A lot of patients will say they feel like the room is moving around them, and a lot of times it's accompanied with nystagmus, which is a physical finding that you can see where the eyes are moving from one side to the other in sort of a beating pattern, either up and down or left to right. Now, pre-syncope, on the other hand, is a different kind of dizziness. It's a lightheaded dizziness, a faintness. You may experience it if you are laying down and you sit up too fast. Just the sort of the feeling that you're going to pass out. So it's really important when a patient says that they feel dizzy or that they get dizzy feelings from time to time, that you ask them to explain how that dizziness feels, because vertigo and pre-syncope are going to be totally different workups. Vertigo is usually a neurological cause, whereas pre-syncope is usually a cardiovascular cause. So looking at vertigo, once you have established that it is indeed vertigo, you're going to want to find out the chronicity of the vertigo. How long has it been going on? How long does it last? And you want to find out, are these episodic or is it constant? You also want to find out, does it change with any particular actions, particularly with position? So we're going to talk about several different causes of vertigo. Vertigo is really just a symptom. It's not a diagnosis. So we're going to talk about some vertigos that are single and prolonged episodes. Among them are vestibular neuronitis, labyrinthine damage or labyrinthine concussion, and lateral medullary infarction or cerebellar infarction. The ones I have noted here in blue are peripheral causes of vertigo, which manifest differently than the ones here that I have labeled in gold, which are central causes of vertigo. Peripheral vertigo generally affects the inner ear and the vestibulocochlear nerve, whereas central causes of vertigo affect the brainstem and the central nervous system. Now, we're also going to talk about recurrent episodes. Recurrent episodes are the ones that come and go. That is Ménière's disease, vertebrobasilar insufficiency, migraine aura, and perilymphatic fistula. And then we'll also talk about positional causes of vertigo, which is primarily BPPV, benign positional paroxysmal vertigo, which is the #1 cause of vertigo in the U.S. And then there are some other causes which we'll briefly address. So vertigo, again, is a common complaint. There are lots of different causes, as we just saw. A helpful approach is to ask how often it happens. Is it episodic or is it a constant issue? Obviously, if it's a constant issue, that's going to be something that somebody comes in more quickly than if it's episodic. If you're constantly feeling the room is spinning, usually you make it to the ED pretty fast. You also want to know, is there any hearing loss associated with the vertigo? Usually, if there's a hearing loss associated with the vertigo, you can almost for sure say that it's a peripheral cause. Not always, but in most cases, hearing loss points to a peripheral vertigo. And then any other symptoms, because that's going to help you narrow down your differential. Now, of course, the most pressing diagnosis to rule out, as you probably saw in that differential of vertigo, particularly in older patients, is infarctions or strokes. So particularly Wallenberg syndrome, which is a infarction of the lateral medulla, and cerebellar infarcts. And then, of course, space-occupying lesions can cause vertigo as well. The base of your index of suspicion should be on risk factors. So immediately when a patient comes in with vertigo, particularly if they're an older patient, you should first thing rule out stroke or an infarction. So if the patient has any other kinds of symptoms that are consistent with a brainstem infarction or a cerebellar infarction, meaning they have other CNS symptoms like hemianesthesias, dysphagia, any other cranial nerve problems, that points you more towards possibly a stroke. And you're going to want to err on the side of caution and rule that out with a CT. Same thing with space-occupying lesions. You would obviously see papilledema. So in either of these cases, if a stroke is a possibility, you're going to want to err on the side of caution, and your first step is going to get a CT. Once that comes back normal, then you can work on your differential. So some relevant anatomy for vertigo, just primarily the inner ear here. So here we're coming in from the tympanic membrane, and then we have our conduction system. And then we have two separate components of the inner ear. There's the cochlea, which is responsible for hearing. That's not as relevant to the cause of vertigo. Then there are the semicircular canals, which go in both the X, Y, and Z direction. The cochlea goes to the cochlear nerve. The semicircular canals go to the vestibular nerve, and together they form the vestibulocochlear nerve, or the cochleovestibular nerve, however you want to say it, and that is cranial nerve number 8. Now the vestibular nerve and the cochlear nerve do separate. They travel together for a while, but they do separate. The vestibular nerve ultimately goes to the ipsilateral vestibular nucleus at the pontomedullary junction, and that ultimately will go to the cerebellum, which makes sense because the cerebellum is responsible for balance. The cochlear nerve, on the other hand, is going to go to the cochlear nucleus, also at the pontomedular junction, and that will ultimately lead to the primary auditory cortex on the temporal lobe. So if you're asking yourself whether this is central or peripheral vertigo, there are some hints that you can gather from the symptoms. So if a patient has other central nervous system symptoms, then you can gather that there's possibly a central cause, like a stroke, God forbid. So diplopia, dysarthria, dysphagia, those are all things that would be consistent with lateral medullary infarctions, Wallenberg syndrome. Ataxia could be consistent with a cerebellar infarct. When we look at the nystagmus, and we almost always have nystagmus when we see patients with vertigo, patients who have central vertigo tend to have vertical moving nystagmus, so the eye is beating upwards. And it's usually more notable when they fix their gaze on something. So if you have them look at something in the room, it's easier to see the nystagmus than if they're not focusing their gaze. Another thing that you won't see in central vertigo is hearing loss and tinnitus. Hearing loss and tinnitus tend to be associated with peripheral vertigo because the things that affect the ear are going to be more likely to cause hearing loss and tinnitus. Now there are exceptions. Certainly a patient who has hearing loss, you can't rule out central vertigo, but the absence of hearing loss and tinnitus point towards peripheral vertigo. Another thing is that central vertigo tends to be the more chronic vertigo problems, the more longer lasting issues, and of course the major exception is infarcts, which can be acute. They are acute, always acute. Now with peripheral vertigo, things like Ménière's disease, you usually will have tinnitus and hearing loss because this is peripheral. It's affecting the ears. It's affecting the vestibulocochlear nerve. A lot of times you're going to have severe nausea and vomiting because these tend to be the patients that have episodic vertigo and it comes on out of nowhere and they wind up with nausea from it. With peripheral vertigo, the nystagmus you tend to see is horizontal. So the way to remember it is peripheral vertigo has horizontal nystagmus. It's just nystagmus that's looking towards the ears, either one. Doesn't necessarily tell you what ear it is, but horizontal, you're looking horizontally towards your ears. So that's how I remember it. And with peripheral vertigo, the vertigo tends to improve. It tends to lessen when you focus your gaze, and that's in contrast to central vertigo. And peripheral vertigo tends to be episodic. Of course, you also need to ask yourself if it's acute or recurrent. So if the patient says that it's an acute vertigo as opposed to a vertigo that is more constant, then that's something that you're going to need to take note of. Physical exam, you need to know how to interpret these three tests. You don't necessarily know how to need to do them per se, but you need to know how to interpret them. And those are the Romberg test, which is universally abnormal with vertigo. That's sort of your field sobriety test, where you ask the patient to stand with their feet at shoulder length, and then after a minute you tell them to close their eyes. If they lose their balance when they close their eyes, that's a positive Romberg's test. The caloric stimulation test we'll talk about in a little bit. That tests the health of the vestibular nerve. And then the Dix-Hallpike maneuver is essentially diagnostic of BPPV, and we'll talk about that when we go over BPPV towards the end. And then finally, it's important when gathering a history to ask the patient, are there any provoking factors, or was there any event that was associated with the onset of the vertigo? So was there anything that happened right before the vertigo started, or was there any trauma? So things to consider, does the head position cause your vertigo? If it does, that points to BPPV. Was there any head injury since you've had vertigo? Has there been any recent upper respiratory tract infection? Was there any pop or sensation changes in ear pressure? Are there any headaches? Those are all going to be important things to think about. And you'll see why when we talk about the individual causes. Okay, so this is the caloric reflex test of the vestibular nerve. You're testing the health of the vestibular nerve. I want to talk about how you do this before we talk about the first major cause of vertigo. So here we have a patient laying on their left side, so this is their right ear. And it doesn't matter what ear you do this in, you're going to do it in both. So this is their ear, and here's their eye right here, nice green eye. First thing you're going to do is you're going to pour cold water in their ear. And what you're going to do is you're going to have them on their side, and you're going to look at the eye and look at what it does. Now, normally, in a normal person, you could do this on yourself, you could do this on your friend for fun. In a normal person, you will get a nystagmus by pouring cold water into your ear. That's normal. If you've ever had your ear irrigated for wax, you'll know that you get that dizzy feeling. In a normal ear, with a normal vestibular nerve, a healthy vestibular nerve, the nystagmus fast beat is going to beat towards the other ear. So it's going to move towards the right if you're pouring it in the left ear, or towards the right if you're pouring it in the left ear. On the other hand, if you pour warm water into the ear, or hot water, not too hot, you don't want to injure the patient, then the warm water, it's going to cause the nystagmus to beat towards the same ear. So the way you remember this is cold goes to the fast beat is towards the other ear, warm, the fast beat is towards the same ear, COWS, C-O-W-S. And this is a normal caloric stimulation test. You could do this on yourself. assuming that you have a normal vestibular nerve function, you would have this normal result, where the cold water would cause nystagmus, fast beating towards the other ear, and warm water would cause it to fast beat towards the same ear. In a patient with vestibular nerve damage, you're not going to have this finding. Either the nystagmus will go towards whatever direction it wants. So it may go towards the same side in both with both cold water and warm water, or it may go towards the other side with both cold water or warm water. Okay, so again, we're going to talk. This is what we're going to talk about here. We're going to focus primarily on vestibular neuronitis, labyrinthine damage, Wallenberg syndrome, Ménière's disease, posterior circulation insufficiency, and perilymphatic fistula, along with BPPV. Okay, so vestibular neuronitis, and this is going to be where your vestibular stimulation test is going to come in. So, as its name implies, this is a disease of the vestibular nerve. However, neurologists really don't like this term vestibular neuronitis because you don't really actually have an inflammation around the vestibular nerve. So a lot of neurologists like to call this vestibular neuropathy, but this is the classic name, so it doesn't really matter what you use. This is an acute peripheral vertigo. It's affecting the vestibular nerve, which is peripheral. Technically, it is part of the central nervous system since it's a cranial nerve, but is peripheral relative to the brain. So this is acute and peripheral, and it's commonly associated with upper respiratory tract infections. So a patient has bronchitis, and then 3 days into their bronchitis, or even after their bronchitis, they develop dizziness. It really is idiopathic. We don't know exactly what causes it. Sometimes we've seen some things in literature that have said that herpes simplex virus may be associated with vestibular neuronitis, but really it is idiopathic. But there is a predilection with upper respiratory tract infection, so that's good to keep in mind. It can happen in anybody, young or old, so history doesn't really matter, except for the upper respiratory tract infection predilection. The symptoms are very few other than vertigo, severe vertigo. So a lot of patients, and this goes without saying for the rest of these diseases, any patient with vertigo can have nausea, vomiting, and imbalance, because vertigo is that spinning sensation, and for a lot of people it makes them sick. So I've had vertigo personally, and I wouldn't wish it on my worst enemy, because this is one of the most unpleasant feelings you can have. You can bury your head in the pillow and it doesn't go away. So, and there's no medication that makes it really go away. So nausea and vomiting galore and imbalance. But really no other symptoms with vestibular neuronitis other than the vertigo. On physical exam, you'll have a positive Romberg's test and an abnormal caloric vestibular stimulation test. So you'll pour that water into the ear, and the nystagmus is going to go whatever direction it wants to go in. Either it's going towards the left or it's going towards the right, but the water is not going to change it. So the abnormal caloric vestibular stimulation test points you towards a abnormality of the vestibular nerve, and so vestibular neuronitis is one of the things that can point towards, but it's not the only thing. An abnormal stimulation test is not diagnostic of vestibular neuronitis. It could be other things that affect the vestibular nerve. But when we're looking with this history on a healthy patient with an acute onset, vestibular neuronitis would be at the top of our differential. The treatment is going to be with rehydration, particularly if they've had a lot of vomiting. So either oral rehydration if they can tolerate it, or IV rehydration. If they're in the ED, you can give them a bolus of normal saline to rehydrate them, especially if their blood pressure is a little bit on the low side, if they show any outward signs of dehydration. And then supportive care, and again, this is going to go both the rehydration and the supportive care. This goes for all causes of vertigo. We do rehydration supportive care for anybody who's had vertigo and has had significant nausea and vomiting. So supportive care for any kind of vertigo is going to include antiemetics, which you can use antihistamines like diphenhydramine or Phenergan. You can also use metoclopramide. Anticholinergics and vestibular suppressants are also good just to calm down the vestibular nerve. You can use meclizine or scopolamine. Okay, so labyrinthine concussion is different, obviously. This is much different than vestibular neuronitis, as you can probably gather by the name. And labyrinthine concussion is an acute peripheral vertigo, but this is associated with head injury or trauma to the ear. So remember, before we talk about this, that any patient who presents with a head injury, usually to the ED, that has central nervous system symptoms, particularly if they have nausea and vomiting, needs to get a stat head CT. That should go without saying, because head injury, head trauma can lead to an intracranial bleed, and certainly the initial manifestations of an intracranial bleed, subarachnoid hemorrhage, any kind of intracranial bleed can be subtle at first, but can lead to really devastating consequences. So any patient who has a head injury and is also symptomatic should get a head CT before anything else is done. Okay, so the history in a patient that has labyrinthine concussion is going to be trauma. So either trauma to the head or trauma to the ear. Generally, they're not going to have really any other symptoms besides vertigo and whatever associated nausea and vomiting and imbalance comes with it. Of course, they could have a abrasion to the head, something that would show trauma, outward signs of trauma. But other than that, there's really no symptoms of labyrinthine concussion besides the vertigo. Physical exam, you're going to see again a positive Romberg sign like in any vertigo, and then signs of head or ear injury on general or otoscopic examination. Of course, you may not see head injury. They might just tell you that they had an injury, but I would expect on the USMLE that you should see physical signs that would corroborate trauma. But you should make sure that you're doing a careful examination both of the head and neck and of the ear. Diagnosis, like I said, any kind of trauma that's coming in with symptoms warrants immediate head CT. Generally, with labyrinthine concussion, the CT will be normal, although there may be fractures of the cranial bones. Treatment is going to be supportive. Vestibular suppressants are often given, as well as antiemetics. If medical therapy fails, if they've gone on for a week or two and they haven't gotten any relief, because this should resolve spontaneously, if medical therapy fails, you should consult ENT. Okay, Wallenberg syndrome. Now, if you watched my lecture on stroke syndromes, you should remember Wallenberg syndrome. And Wallenberg syndrome is an infarct of the lateral inferior medulla. And the inferior medulla has multiple different nuclei and structures that are responsible for nervous function, including the vestibular nucleus. And the vestibular nucleus, of course, is the termination of the vestibular nerve. It terminates in the inferior medulla and then goes towards other parts of the brain, particularly the cerebellum. Now, Wallenberg syndrome is a stroke of the posterior inferior cerebellar artery, and you should know that because a lot of times on the USMLE they'll give you symptoms and they're not going to ask you what's the diagnosis, because a lot of people know Wallenberg syndrome is imbalance, and it's hemianesthesia of the face and contralateral hemianesthesia of the body. But they will want you to know the anatomy. So they'll want you to know that it's the posterior inferior cerebellar artery. So here you see that the vestibular nucleus is part of the region of the inferior medulla supplied by pica, and also the spinothalamic tract, which is responsible for relaying pressure, temperature, and crude pain, or crude touch and pain from the body. Now, because the face is ipsilateral, it doesn't decussate. Anytime you have an infarction here, it's going to be the ipsilateral face where you lose the sensation, and of course the contralateral body because it's the decussation is below. Okay, for more information on this, you can look at the stroke syndrome lectures. Okay, so this is an acute central vertigo. So remember that your nystagmus would be upbeating in central vertigo. And it's secondary to an infarct of the lateral medulla, and it is associated with other CNS symptoms. And you know that just because of what is around here. So look at what you've got here. You've got your vestibular nucleus, yes, but you also have your spinothalamic tract carrying information about sensation. Not a lot of things cause vertigo that also cause sensory hemianesthesia other than Wallenberg syndrome. So that's going to be a big hint. Another thing is that it carries the tract of the trigeminal nerve. So you can get some issues with speech. It also carries the part of the vagal nerve, and so you can have Horner syndrome. Which remember is Horner syndrome actually is with the sympathetic nerve, but with the vagus nerve, it can cause dysphagia as well as hoarseness. So lots of different neurologic problems, all related to the fact that you have an infarct of the lateral medulla. Remember, the more nervous symptoms you have, the more you should be thinking about an infarct. So severe vertigo, nausea, vomiting, facial hemianesthesia, contralateral body hemianesthesia, dysphagia, dysarthria, and Horner syndrome are all associated with Wallenberg syndrome. History, of course, these are going to be older patients because older patients tend to have more risk factors for stroke. Age itself is a risk factor, also hypertension, smoking, hyperlipidemia, hypercoagulability, and atrial fibrillation. As far as making the diagnosis, based on the clinical presentation, you should be making this diagnosis. So if the patient comes in and they've got this hemianesthesia, part on the face, and then on the contralateral body, that's like textbook Wallenberg syndrome. So immediately they should be getting a CT. But with dysphagia, dysarthria, along with vertigo, those are lesions that have nothing to do with each other. So you should be thinking central. And so you should be getting a CT, particularly if they're patients with risk factors for stroke. So I can't emphasize enough, if it appears to be an infarction, any kind of infarction pattern, you should be getting a CT right away. And that just goes for anything with stroke. Best initial test is a non-contrast CT. As far as treatment, it's just going to be your typical stroke protocol. So if the patient is presented within 3 hours of symptoms, you're going to want to assess them for eligibility and then treat them, if appropriate, with TPA or alteplase. Okay, so moving on, Meniere's disease is a recurrent peripheral vertigo, and it's strongly associated with these hearing symptoms. So tinnitus, which is the ringing in the ear, and progressive hearing loss. So this is something that doesn't just strike you all of a sudden. It's something that kind of comes on gradually. So what this is caused by is unilateral intermittent increases in the perilymphatic volume. Whoa, that's a lot of words. Okay, so let's backtrack there. You have fluid, perilymph, in your semicircular canals. So Meniere's disease is where you have an increase of that perilymph volume, meaning then that you're going to get an increase in pressure because you only have so much space. So when you get that increase in pressure, that's going to stimulate the vestibular nerve. And so you're going to have abnormal vestibular function because on one side of your head, in one vestibular nerve, you've got extra stimulation because of the increased pressure. On the other side, it's normal, so you've got an abnormality. A lot of patients, most every patient who presents with Meniere's disease are going to complain of this sort of progressive hearing loss and tinnitus and dizziness. So that triad together is very specific for Meniere's disease. And another thing they say is this feeling of fullness in one ear. And that makes sense because you have this perilymphatic pressure. And so if you have this extra pressure, it would make sense to have a feeling of fullness. And it's in one ear, not in both ears. This ultimately causes progression of hearing loss and this constant ringing when it's not treated. And the symptoms can wax and wane, and that's just because the perilymphatic volume can wax and wane basically with your blood pressure. So like any fluid space, the higher your blood pressure is, the more fluid is going to be extravasated into that space. And that's going to make sense based on how we treat this. So diagnosis is primarily clinical based on their presentation, and the unilateral and chronic nature may incline you to think about an acoustic neuroma. Acoustic neuromas are rare, but if the patient has neurofibromatosis, then you certainly would want to get a CT in that case. But there's not many things that cause unilateral and chronic vertigo and hearing symptoms. So that's part of your differential, but Meniere's disease is generally the more common cause. But acoustic neuroma can present in a similar way. On physical exam, you should ensure that there is an abnormality in hearing, and unilateral hearing abnormality, conductive hearing loss would support the diagnosis. The treatment is supportive. Again, we're giving typical supportive therapy for vertigo, any kind of fluid replacement if it needs to be done, any kind of antiemetics, vestibulosuppressants, and so forth. Another thing that is useful for Meniere's disease is Lasix or any kind of diuretic for that matter. So low sodium diet and diuresis can be good for Meniere's disease, and that kind of goes back to the fact that this is a disease where they've got an increase in the perilymphatic volume. So the thought is if you keep their vascular volume at low normal, then you'll keep their perilymphatic volume as low as you can keep it. But certainly you're not going to want to dehydrate these patients. Diuretics, gentle diuretics can be useful, but primarily the therapy is supportive. If this goes on for a long period of time, you can get surgical therapy for this, but that's secondary. And so here's sort of a picture of what Meniere's disease looks like. So this is a normal inner ear, and then this is your increased pressure, increased perilymphatic pressure. And so this causes, this is your vestibular nerve here, and here's your cochlear nerve. So that's going to just cause extra stimulation of the vestibular nerve, abnormal stimulation. Okay, perilymphatic fistula. This is rather uncommon, but it is something to keep on the differential. So this is a recurrent peripheral vertigo, and this is caused by a rupture of the bony capsule in the inner ear. You have this small bony capsule in the inner ear. If this ruptures, this can result in a leakage of perilymph, that same kind of fluid. And if that ruptures, obviously, and you're getting a leakage of that fluid that's in the inner ear, that can also cause dizziness and vertigo because it's affecting the vestibular nerve. So a history is really useful in diagnosing this condition because a lot of times the patient will have this acute onset of vertigo, and it's associated with this pop sensation. And if you've ever gone on an airplane and you've had your ears popping, it's kind of like that, but it's a lot more profound. And so this popping sensation is associated with a sudden increase in middle ear pressure. And so anytime you're doing a Valsalva maneuver or straining or coughing or sneezing or giving birth, that can cause a high enough increase in the middle ear pressure to where you can develop this fistula, where it breaks this bony capsule. And so other things to think of are like pilots or scuba divers, things like that. So symptoms are similar to Ménière's disease because this is a recurrent and peripheral vertigo, and it also causes a sensation of fullness and a progressive decline of hearing. I'm not exactly sure what the mechanism behind why it causes that direct sensation of fullness and decline of hearing is, but it does cause that. So this is very similar in presentation to perilymphatic fistula, or sorry, to Ménière's disease, but the difference is going to be in the history. So differential in general from Ménière's is pretty elusive, and so it's going to be based on your history. But if a perilymphatic fistula is suspected, if the patient can associate this, if they do say, yes, I do think that I experienced this pop in my ear and that was the beginning of my vertigo, or yes, I am a scuba diver, or yes, I am a pilot, then you should be getting an ENT consult immediately, because ENT surgery is a little bit easier with perilymphatic fistula and tends to have a better cure rate, so to speak, than with Ménière's disease, where it's a little bit more difficult to treat with surgery. So we're going to consult ENT sooner than we would with Ménière's disease if the patient does indeed if they are indeed suspected with perilymphatic fistula. Apart from that, though, medical therapy is the exact same. So treating their nausea and vomiting, treating their depleted fluid status if they have it, and antiemetics. Okay, so if you watched my stroke section or stroke syndrome section or anatomy section, you should be very familiar with the posterior circulation as well as the anterior circulation and the circle of Willis and all of that. So this is the posterior circulation originating from the vertebral arteries, both left and right, and the anterior and posterior spinal arteries. Posterior spinal arteries not seen here. But this is the posterior circulation. It primarily feeds the brain stem, as well as the cerebellum and the occipital cortex. So, vertebrobasilar insufficiency can cause recurrent central vertigo, and these come in as spells. And this is really, really similar to jugular venous syndrome. So, or I'm sorry, to carotid artery syndrome. So this is essentially the same thing as you have in your anterior circulation. Your anterior circulation is your carotid artery. Your posterior circulation is your vertebrobasilar circulation. So what you have here is insufficiency of your vertebrobasilar circulation, and it causes a intermittent hypoxia of the cerebellum or the brainstem or the occipital cortex. Now this, of course, can cause vertigo because remember that the brainstem and the cerebellum are all responsible for balance, and your brainstem, particularly your medulla, receives your vestibular nerve. So if you have any kind of ischemia in these parts of the brain, even transient ischemia, it can cause vertigo. So this is an important diagnosis to remember on your differential because of the risk that it implies. If a patient does have vertebrobasilar insufficiency, they are at increased risk for vertebrobasilar or theoretically any kind of stroke because it shows that they do have some vascular disease going on. So patients with vertebrobasilar insufficiency generally have multiple risk factors for stroke: age, hypertension, high cholesterol, hypercoagulability. And so a lot of times these are going to be older adults that present with this. So any patient with recurrent central vertigo should be worked up for vertebrobasilar insufficiency. Now this is different from Ménière's disease, which is also common in older adults, because this is a central vertigo, whereas Ménière's disease is a peripheral vertigo. So this is a vertigo that should be upbeating. Now the symptoms apart from vertigo, of course, are any symptoms that involve parts of the brain that are fed by the vertebrobasilar systems. So cerebellar symptoms, brainstem symptoms, and occipital cortex symptoms, which, remember, the occipital cortex houses the primary visual cortex. So you can get symptoms such as visual changes, diplopia, numbness and tingling, weakness, dysarthria, and dysphagia. And a lot of times these are going to be sudden attacks. So they come and they go away. And that's typical of any kind of insufficiency. Like in carotid insufficiency, you get that sort of dizziness, sort of stroke feelings, but they come and they go really quickly. They're not your long-lasting sensations that you would have if you had a TIA or a stroke. So these are sudden attacks, but then they go away. Now, it's always important to keep a high index of suspicion for vascular disease in patients with risk factors for stroke, as mentioned. So if this is an older patient with recurrent central vertigo, then VBI is the most likely diagnosis. And like in any patient where we're suspecting possible TIA, stroke, insufficiency syndromes, the best initial test is going to be a CT. And even though VBI does not imply damage to the brain, non-reversible damage to the brain, it's important to initially get a CT to see if there is any ischemic damage that has already occurred. And then after that, you can follow it up with an angiography, either a traditional angiography or an MR angiography, to identify any stenotic vessels that are present. So this is really similar to patients with carotid artery disease, both in the workup, in the pathophysiology. The only difference is, of course, in the symptoms, because it supplies different parts of the brain. So how do we treat this? We want to reduce modifiable risk factors, like in any patient at risk for a stroke, to reduce their future risk. Commence antiplatelet therapy. That'll also decrease their risk, and various surgical repair therapies are out there, and this can be done if it's deemed necessary by a vascular surgeon, who of course should be consulted if a patient has vertebrobasilar insufficiency, or if they have carotid artery disease for that matter. However, the particular therapies, surgical therapies for vertebrobasilar insufficiency, are outside of the scope for the USMLE. So unlike carotid artery stenting or an endarterectomy, the particular therapies as far as surgery for vertebrobasilar insufficiency and when you need to do them, you don't need to know for the USMLE. Okay, finally, we have benign positional paroxysmal vertigo. And this is a very unique type of vertigo, and it is the most common. And it is actually probably one of the easiest to diagnose. So that's kind of nice. And I guarantee you'll get a question on this on the USMLE, and you've probably seen this on wards just because it's so common. So this is a recurrent peripheral vertigo, and it's caused from the dislocation of these calcium carbonate otoliths, that reside in your semicircular canals. And notably, BPPV is exacerbated with changes in head position, just as its name implies. So these otoliths are not things that are abnormal. These are normal little rocks that exist in your semicircular canals. And what they're responsible for is telling your semicircular canals, telling the nerves that reside there, where is your head relative to space. If you close your eyes, you should know where your head is relative to space, and that's because your vestibular nerve is telling you. And it's the otoliths that change positions and can tell the nerves in your semicircular canals, which then go on to feed your vestibular nerve, which then go on to go to the vestibular nucleus, which then goes to the cerebellum and tells your brain where your head is relative to space. So you can see that if you dislocate these otoliths and they're not working properly, then you've disrupted that entire cycle. And it does cause vertigo, and it is the most common cause of vertigo in the US. So history-wise, this is incidental. There's really nothing that we know that dislocates otoliths. There's not necessarily any kind of trauma that necessarily has to be associated with this. However, sometimes there is ear trauma associated with BPPV, but not always. So you don't have to have ear trauma to diagnose BPPV. But it is dislocation of the otoliths in the semicircular canals. It's incidental. It tends to be in older patients, though. That's just how it tends to be. You can be a younger patient, but it tends to be in older patients. Symptoms, again, are vertigo, nausea, vomiting, imbalance. Remember, with the vestibular nerve, ultimately it's going to the cerebellum. It feeds nerves that will go to the cerebellum. So this is important for balance. So anything that causes vertigo can cause balance problems, can cause gait issues. But it is exacerbated with changes in head position. So that's going to be what's most important for diagnosing BPPV. If it's vertigo that is worsened with head position, but if you keep your head in a certain spot, certain position that you're okay, then that really makes you think BPPV. So usually the vertigo here comes on severely and then dissipates within a minute. And that makes sense because what's happening is those otoliths are moving around in abnormal places where they shouldn't be. They're causing the vertigo, but then once they settle back down, your vertigo dissipates. So it comes on severely and dissipates well under a minute. And there are very few other symptoms with BPPV that aren't related to the vertigo. So the diagnosis here is quite easy. There is a maneuver that you do, and it's the best initial test for diagnosis, and it is the most accurate test, and it's called the Dix-Hallpike maneuver. And you don't need to know how to do this test for the USMLE. It's kind of good to know how to do it for wards, but if you don't know how to do it, certainly your friendly neurologist will. And this maneuver should elicit nystagmus, and the fast phase will be towards the affected ear. So remember, with the Dix-Hallpike maneuver, you're going to get nystagmus, and the fast phase points you towards the affected ear, and a positive Dix-Hallpike maneuver will elicit nystagmus. So let's go back. If you have a Dix-Hallpike maneuver, if you do the Dix-Hallpike maneuver and it elicits nystagmus, that's positive, so then you know you have BPPV. And then you look at the nystagmus, and the side that the fast beat is towards is the affected ear. So it is on that side where you've got the dislocated otoliths. The treatment is the Epley maneuver, and this is kind of based off of the Dix-Hallpike maneuver, but it's different. And what you're doing here is you're repositioning your otoliths back into the appropriate position. So if somebody was really, really, really clever and came up with this position a long time ago and figured out the pathophysiology and how we treat BPPV, and this is still the treatment for BPPV. Sometimes most of the time it's effective, more than half the time, but sometimes it's not. And so if it's not effective, and in some cases it's not entirely effective, it can reduce the symptoms, but not entirely get rid of them. Sometimes you have to wait a little while. So any kind of residual symptoms You guessed it, supportive care. So antihistamines, antiemetics, vestibular suppressants, and so on and so forth. So this is the Dix-Hallpike maneuver. You're taking the patient, you're supporting their head, and then you've got them towards the back of the table. And what you're doing is you're moving them quite quickly because you want to stimulate the otoliths to move, and you're moving them down to a flexed position with their head back and pointed 45 degrees towards either the left or the right. And if you have nystagmus, it's positive. And the side that the beat is towards, the fast beat, is going to be the affected ear. So this is how we diagnose BPPV. And of course, you should be gentle. You want to be firm because you want to get your result, but you got to be gentle, of course, with fragile patients. And then this is the Epley maneuver. I'm not even going to try to explain this. I don't even think I really understand this. This is generally done by a neurologist. They have really good experience with this, or sometimes there's auxiliary medical personnel who know how to do this, rehabilitation therapists. And Epley maneuver, though, is the therapy for BPPV. Okay, so there are some other possible causes of vertigo. I excluded them from talking about in detail because a lot of times these present with symptoms other than vertigo as the most prominent symptom. So multiple sclerosis, vertigo is the presenting symptom, but only 5% of the time. So with multiple sclerosis, there are generally focal neurologic signs, particularly numbness, tingling, weakness, diplopia, eye pain, and on CT, focally enhancing white matter lesions. In young patients, if you have CNS signs, especially if they've lasted a while, if they come on in spurts and then they go away, we're thinking multiple sclerosis. We're always concerned about this diagnosis, especially when you have weakness. Or if you have optic neuritis, which is the eye pain on motion and diplopia. Panic attack can result in what appears to be vertigo. Of course, these are going to be patients with classic panic symptoms that they can associate with the vertigo. These are going to be short-lived, and it's going to be difficult to elicit the vertigo. A lot of times you're not going to see it while the patient is in. Very rarely are you going to see, I would say probably never, are you going to see nystagmus with panic attack. So this is something that feels like vertigo. The patient may say they feel like it's spinning, but it's really not vertigo. So you have to tease out those psychiatric issues and see if this is more related to a panic attack or if this is actually related to an organic neurologic issue. Ramsay-Hunt syndrome is a complication of shingles. This is going to usually be a little more obvious looking at the patient. Most patients with Ramsay-Hunt syndrome have a pretty dramatic facial muscle palsy, so if you tell them to clench their teeth together, one side is going to be kind of weaker, paralyzed. You'll also see some vesicles on the tympanic membrane on otoscopy. You can also see vesicles around the pinna and in the outer ear. And you can also see vesicles on the hard palate of their mouth. So this is a shingles infection of the facial nerve, and it also gets into the ear as well. So Ramsay-Hunt syndrome, particularly if you want to be exact, Ramsay-Hunt syndrome type 2. Ramsay-Hunt syndrome type 1 is actually a central nervous system disease of the cerebellum. It has nothing to do with type 2. So this is Ramsay-Hunt syndrome, technically type 2. Cholesteatoma is particularly you're going to see this in pediatrics. It's a waxy white-yellow tumor, and it grows. So this is a progressive problem. A lot of times you'll see this on otoscopy. It looks like earwax, but you're not going to be able to get it out. So this is usually seen on or around the tympanic membrane, middle ear. And these patients tend to have a history of chronic ear infections. A lot of times you'll see some drainage, and there can be some conductive hearing loss. So make sure that you know how to do your Weber's test for for any kind of hearing loss, because that's going to point you towards conductive hearing loss. Remember the Weber's test? You hit the tuning fork, you place it on the top of their head. If it's louder on one side than the other, then that's a Weber's positive sign, and that points towards conductive hearing loss on the louder side. And the reason is because whatever's blocking the hearing on that side, it's also blocking noise, ambient noise from the room. And so the noise that you get from the bone vibration from the tuning fork is going to be easier to hear on that conductive hearing loss side. So otosclerosis is something to think about, cholesteatoma is something to think about in a child with hearing loss who also has dizziness or drainage or something that you see on otoscopy that looks abnormal, like wax, but isn't wax. Otosclerosis is an autosomal dominant disorder. It's a thickening of the bones of the ear, and it also is a conductive hearing loss issue. So again, you'll have a positive Weber's test lateralizing to the affected ear. Otosclerosis and cholesteatoma very rarely present with vertigo, along with some of these other ones. So with these, I only included these for the sake of completeness. These very rarely present with vertigo. And then a migraine can present in its aura phase with, can be similar to vertigo where you have that spinning. It's not vertigo, but in as much as you can't really treat it because it's an aura of migraine, you can treat the migraine, but you can't really treat that vertigo because you never know when it's going to come on. And then with seizures, you also have an aura phase. Most patients with seizures have aura phases, and they can experience the spinning sensation that is commonly experienced in vertigo. And then definitely know your drugs that can cause vertigo, particularly the antibiotics known as the aminoglycosides. Aminoglycosides are ototoxic, so you have to know that for the USMLE, especially the aminoglycosides. Other diuretics, like furosemide, can cause vertigo, but it isn't common. Antihypertensives, antidepressants, and alcohol. You don't have to worry about these necessarily. I mean, you don't have to worry about using these in a patient with vertigo. These aren't, probably besides the aminoglycosides, these aren't necessarily contraindicated in a patient with vertigo, but they can cause vertigo. So if you look at a patient's medical history and they're taking furosemide or they're taking gentamicin, then that could be a cause. So that's why I included this. Okay, so here's the cholesteatoma. This is what it looks like. This is this is a really, really, really difficult one to see. Here's one that's a little more obvious. I would expect this on the USMLE. It looks like wax, presents not similar to wax, doesn't come out. And then this is Ramsay-Hunt syndrome. So this is your triad here of your lower motor neuron, paralysis of the facial nerve. You have a loss of taste sensation on the anterior tongue, and then this vesicular rash on the external ear, which you may see some vesicles on the tympanic membrane. And that is the arduous end of vertigo.